Hello, everyone. I'm Brendan Hawker with the Open Minds Market Intelligence team, and I would like to welcome all of you to today's Circle Elite Executive Roundtable, bringing care to consumers through street outreach, the Access Services case study. Today's roundtable features Deborah Curtin, Mark Boers, Casey Fenolio, and Halle Van Vliet. Deborah Curtin is the Senior Director for Behavioral Health at Access Services. In this role, she has been significant in fundraising and advocacy to support new housing and homeless programs. Prior to this role, she was the director of the Homeless Street Outreach Program and was involved in the program's initial startup and implementation. Ms. Curtin's experience in human services includes work in the mental health, housing, and homelessness, and children and family service systems. Ms. Curtin is passionate about integrated health, community service, and collaboration across service systems. Mark Boers is the Director of Program Development at Access Services. In this role, he has been instrumental in the design and startup of the Homeless Outreach Program through Access Services, which provides health care to individuals experiencing homelessness in Montgomery County, Pennsylvania. He was also integral to the design and startup of the pilot street medicine program in Pottstown, Montgomery County, Pennsylvania, which is about 18 months old. As part of the street medicine team, he fills the role of street outreach guide, bridging the gap between homeless community and the medical providers on the team. He is passionate about helping marginalized community members gain access to care that promotes whole person health. Casey Fenolio is a community wellness program manager at Pottstown Hospital Tower Health, and also serves as the vice president of the board of directors for Tri-County Community Network. Prior to joining Pottstown Hospital in 2019, Ms. Fenolio's public health experience ranged from university research to school wellness to health education and prevention for a national nonprofit organization. In her current role, Ms. Fenolio works to identify and address the community health needs in Pottstown Hospital's service area. Halle Van Vliet is a board-certified emergency medicine physician practicing in Pennsylvania with Tower Health Medical Group. She completed her undergraduate studies in neuroscience at Vanderbilt University before obtaining her medical degree from the University of Rochester School of Medicine. Her training in emergency medicine took place at the University of Wisconsin Hospital and Clinics. Moderating today's roundtable will be Sharon Hicks, Senior Associate at Open Minds. Sharon Hicks has been a Senior Associate with Open Minds for the past 7 years. Prior to joining Open Minds in 2015, she spent 35 years in the public health sector of behavioral health, serving in a variety of roles. Beginning her career as a clinical social worker and ending as the Chief Operating Officer of a Medicaid behavioral health managed care company, Ms. Hicks brings her experience in many levels of clinical service delivery and insurance operation to her current consulting practice. Before we get started, a few housekeeping reminders. As always, your audio will be muted during today's briefing. However, we encourage you to submit any and all questions you may have using the question box located on the right of your screen. We will present audience questions at the very end. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Sharon, I'll turn it over to you.
Thanks, Brandon. Welcome, everybody. So excited to be talking about this incredibly important topic today. Just as a little introduction, it's very clear that we have a significant disconnect between physical health and human services in this country. As early as 2003, work from people like Jeffrey Brenner and others really indicated that this whole kind of new system of multidisciplinary coordinated care, treating a whole patient, is what's needed. And there are significant studies and data that demonstrate the value of looking at a whole person, including all of their social service needs. In the rest of the world, they figured this out maybe a little earlier than we did. If you take a look at this particular graph, you see that while on average the other members of the economic development environment, there's about 37 countries, spend about $1.70 on social services. For every dollar on health services, the US spends 56 cents on social services for every dollar on health services. And so it's this kind of disproportionate spend, I think, that we're really talking about today. So again, just taking a look at the total, everyone talks about how expensive healthcare is in the United States, but when you take a look at us on the same, axis as other countries, you see that we don't actually spend that much in total, but we spend a significantly less amount of money on social services. And of those social services, homelessness is especially insidious. The homeless problem in this country is huge. We have average life expectancy of people who are homeless much, much lower by a factor of 2 than people who are not homeless. We have a significant problem with LGBTQI plus children. We have problems in almost every large city. And the good news, and what we're going to hear about today, is that people are starting to realize, states are starting to put housing programs and processes and funding into their Medicaid state plans. Permanent housing interventions have grown significantly. More and more states are realizing the value of a housing first model and realizing that if you get people safely housed, you actually do a better job in decreasing their total overall medical spend, increasing their health quotient than you do by just trying to pay attention to whatever brings them into the emergency room. So with that, let me turn it over to Mark. And let's hear about all of the excellent work that the folks at Access Services are doing.
Thank you, Sharon. Oh, I'm sorry, there we go. Sorry. Oh, now oh no. Here we go. Thank you guys, and thanks for having us, and thanks for joining us in this conversation. We're really having this conversation on 2 levels. The first level is at 30,000 feet, where we're going to describe our process of starting a pilot project to provide street medicine in Pottstown, which is a borough of Montgomery County, which is a suburban county outside of Philadelphia. So we're going to describe that project a little bit to you. And what it took and what we've learned as we've moved from a pilot into sort of a sustainable phase at this point. The second part of the conversation is really at 50,000 feet, and that really is a question of how do you provide services to a hard to serve population, people who present with complex healthcare needs, multiple needs, the social determinants of health that we've just been talking about. When they present with all of those things and they're using very costly services but not using them very effectively, what are the things that we do to address those needs? So maybe your question today is how to start street medicine, and hopefully we'll give you some ideas about how to get started with that. Maybe your population is different than that, but as you think about your population, they present with some of the same characteristics as the groups that we're talking about. So those are the 2 things that we're going to sort of be the 2 levels that we're going to be talking at. We're coming to this conversation through the lens of 3 things that we believe are sort of the grounding principles, the mantras that we are giving you that we hope that are the takeaways, the big takeaways of our time together. The first is that you have to develop relational partnerships, typically with people that you had not partnered with before, and these are a range of partnerships. So it's not just the standard MOUs or business arrangements that you might have with other service providers. It includes those, but it goes beyond that. The second is that you have to understand your local environment. Who are the people? Where do they live? Who are they connected to? What are their support systems like? And how do you get connected and proximate to those people? And then the third one is that you have to adjust the way you provide a service, and we'll demonstrate that in some of our slides that you'll see. There's a continuum of how readily able providers are to adjust what they do typically in order to better effectively serve the needs of a harder group of people to serve. So those are the 3 principles, the lenses through which we're going to we're going to have this conversation. I can't advance the slide. There we go.
I'm going to talk a little bit about how we got started. So Access Services, we added the Homeless Street Outreach Program to our behavioral health service line in 2017. And while providing the components of that service, we became very proximate to the population, to the homeless community. And we saw the gap in medical care for our people. As part of our work, we build partnership because we know it improves our service and because we don't do everything. As much as Mark and I like to joke in the beginning that we were doctors, we're just not. So in the design pilot for street medicine, we knew we would need a strong partnership. So through partnership, we were able to make connections with champions in the local community space for street medicine. With an innovation and capacity grant through the Health Spark Foundation, we solidified partnership with Tower Health, the local hospital and emergency department that was already providing acute care for homeless community members, with community health and dental care, the local FQHC, and with local grassroots organizations, a community behavioral health center, Mission First, the Recovery and Learning Center, and Creative Health Services. So we each brought our own skill set to the collective venture. Access Street Outreach delivers the engaged relationship with the homeless community, the capacity to prepare for street medicine through the day, and the follow-up afterwards. Our street medicine guides coordinate care. Tower Health and the FQHC bring the actual medical care. The FQHC also supports substance abuse disorder intervention. Other community partners provide additional support for us for food and recovery. We believe the foundation of Access Street Medicine is partnership because you just cannot have true integration of services without it.
Thanks, Deb.
Thanks.
This photograph is a demonstration of all that we've just talked about. This is a COVID vaccination site. The Department of Public Safety was tasked with the job of vaccinating hard to find and hard to vaccinate people. So they called us up and said, can we tag along with your street medicine team when you go out on rounds, because we know that you guys see people that we're looking for and we want to vaccinate. So that happened. And then we said, there's also a church that does a community dinner every Wednesday evening. They serve 100 to 150 people every single week. And so they know who's out there in the neighborhood, and they can get us in front of people that need the vaccination, and we'll be grateful to have it. So that's what's happening in this picture. It's just before the dinner is served. The church behind you has volunteers that are setting up for the meal. They know everybody. They know the faces of the entire neighborhood. And the gentleman whose back is turned to us in the center of the picture is a man experiencing homelessness. He's since inside, but he is a fixture of that local community. Everybody knows him, he knows everybody, and he took it upon himself to be sort of like the carnival barker and bring people in. So he said, get your meal here, you want a vaccination for dessert, and it was very successful. We were able to vaccinate a lot of people. The Department of Public Safety knew that they needed to adjust their service delivery. They needed to go outside and go to people in order to do that. But they couldn't just go out because they didn't know where to go or how to get that done. So they partnered with people who did know the neighborhood. So those are both of the other two pillars, knowing the local context and partnering. And the partnership was really with a set of informal people, informal groups that just serve the community really well. And so that's an example of how those things just needed to go together. I don't have control of the screen. There we go. This picture, I'm sorry, somebody. Somebody else is controlling the screen right now. Sharon or Brandon?
Hi, I'm here. I think Sharon's going back to the side you guys are on. Apologies for the tech troubles.
All right, whoever's controlling the slide deck, can you go to the next slide? Okay, thanks. All right, we're back on track, guys. This picture is in a Walmart parking lot, and the thing that's important about this picture is that there are 5 different services represented all in the same space. And so one of the important things about serving this population, the homeless population, is to bring everybody out on the street at the same time. So it's not just partnership, but it's real-time partnership. So everybody can do the thing that's in their lane to do, but we're able to coordinate that effort to provide the whole healthcare that we've been talking about. And so there's emergency medicine involved. There's primary care. There is substance use services and mental health services, all in that same parking lot. The gentleman on the left is the person who's receiving care. One of the things that's also interesting is that at the bottom, the last bullet that says, let the street build the program and adapt to your local situation. There was a growing number of homeless individuals in the Walmart parking lot, and that grew to about 8 or 9 cars, 8 or 9 vehicles, and then they were all kicked out at one point. And so they disappeared, and we had to go elsewhere to find them. But we learned to go to the Walmart because we saw that there was a growing group of people who were there. When we first started in the winter, there was nobody there, and we were meeting people at the few locations in the middle of the pandemic where people could get inside. The other thing that was interesting about this picture is that although he had a car, it wasn't functional, and so we had to arrange transportation for him to get to the clinic. And again, his needs were very complex, and he needed to be in primary care to get the follow-up care that he needed, and also to see the specialist that he needed. So the partnership was important. Bringing people together at the same point in time was important. The real-time communication, and then adapting the service to where the people are migrating. We sort of migrated with them. Can we have the next slide, please?
So I just wanted to touch on the medical component of what we've been doing a little bit. So the medical component really started in January of 2021, and I was lucky enough to be the first physician to go out with the team. Just to give you a little bit of a context, this picture is from a local motel where some of our patients were housed for medical respite, and where some of them had temporary housing provided by other community services within our area. So since we started in January of 2021, we have had 174 different patients that we have had the pleasure of providing care for. Those 174 patients have provided us with a total of 539 separate encounters. The encounters that we have had, our top 3 issues addressed during those encounters include primary care needs. So that would include medication refills, checking blood pressure, and also connecting people with our local FQHC. Behavioral health care needs, whether it's been depression, schizophrenia, or substance abuse issues. And then the third top issue we've addressed has been wound care, often related to IV drug use, but other issues as well. As you can imagine, living in the woods, living on the street, it's easy to end up with wounds that need to be addressed. And these are pretty significant wounds often that would otherwise lead to hospitalization, potentially sepsis, if not addressed in the field appropriately. 32% of our patients have both behavioral health needs as well as physical healthcare needs. And so you can see that there's a complicated overlap here. And behavioral health, as we all know, is inadequately addressed in this country to a large extent just because of the minimal resources that are available. And so that's something that we're continuing to try and tackle as we move forward. I wanted to give you a specific example of what one of our patient encounters might look like, particularly from a longitudinal perspective. So we had the pleasure of meeting a gentleman, and I'm going to use a different name and kind of vague factors just for patient protection purposes, but we'll call him James. And he was in his, I believe, 50s to 60s. He had first met Street Outreach Services, I believe, in January, so they were familiar with him. But he had always been kind of bundled up in the winter weather. And ultimately ended up being placed in this hotel just because of the extreme conditions outside. And so one of the local organizations had provided him with this temporary housing. And he was married, had a significant other, also homeless, obviously, who was staying with him. We first realized that James had an issue after seeing him in the motel when he wasn't all bundled up, and there was a large neck mass that was evident that he hadn't mentioned or brought to anybody's attention. And apparently the mass had been there for quite some time pre-COVID. He had tried to address it. His understanding was that it was benign, nothing serious. And so during the COVID pandemic, he had just kind of gotten lost to follow-up. When one of our providers saw him, we ended up getting him into the emergency department for further assessment of this mass, which we were very concerned was in fact a malignancy. And unfortunately, that did turn out to be the case. He was not admitted to the hospital as he didn't meet any specific acute inpatient needs at that time. But what we were able to do remarkably well was coordinate his outpatient care. So we got him hooked up with oncology, including radiation oncology. He started chemotherapy, had a chest port in, got radiation to the neck. And then unfortunately, but ultimately was also connected with palliative and hospice resources, as this turned out to be a rather advanced case of cancer. And so despite our best efforts, he ultimately did decompensate. We were able to provide medical respite for him. Access Services provided that at this local motel. And ultimately, after he did pass, we were able to provide appropriate support for his wife, which was, I think, a really significant success for us, because she had a history of some substance abuse issues. I think it may be some other mental health issues. And so making sure that she had appropriate support during his passing was a very, very important in making sure that she didn't decompensate and require additional healthcare resources or inpatient needs. And ultimately, we were even able to provide cremation services for him. So making sure he had a dignified passing, and that again his significant other was receiving the support that she needed. So just one example of the success that we have experienced in the provision of medical care.
Next slide.
So I'm going to talk a little bit about, that was a review, thank you, Dr. Van Fleet, of our overall program outcomes and success. One area that I think is very unique to our street medicine program compared to other programs across the nation is the success that we've had with bridging the gap to in-office primary care. When we started this program, we knew that we didn't just want to continually see patients on the street. We really worked to build relationships with the patients that we were seeing so that they felt comfortable entering an in-office setting where ultimately they can get more comprehensive care. One example, we have a patient that we see in street medicine. Between February of 2021 and October of 2021, so less than a year time, this patient came to the emergency department 66 times. 66 visits in about a 9-month period. You can do the math on how many times a week, and I think that's a couple times a day sometimes. Definitely, we have high users in our ED that fall into this homeless population, and we knew we wanted to address these concerns. The interesting part about this specific patient is that in around June, we connected with the patient through Street Medicine, and also connected that patient to our local federally qualified health center for primary care needs. And so when you break down this patient's visits in the emergency department, 48 of them were between February and June, and only 18 visits between June and October, when that patient had started engaging with us outside in the community. Now, I'd like to say that 18 ED visits, it's still a lot more than we would like to see and hope to see for any of our patients in the community, but certainly a significant decline from those first 5 months of that scenario. And so reducing our emergency department visits ultimately saves costs. And our goal is to get people into in-office primary care. We're able to engage with them, of course, certainly in the street, and we do that until they're comfortable. There's no force to get into the office. We're just continually working to build relationships so that people do feel comfortable accessing those in-office services. Now, our specific program really utilizes our local federally qualified health center. In the picture on the screen, you will see Gladys. Gladys is a rock star community health worker. If there was a gold star medal that I could give her, I'd give her one daily. She is a mountain mover and one of the key pieces to the success of our program. Gladys works at our federally qualified health center in the community, which I will note is not a Tower Health entity. They are just a community partner. And she truly works to move mountains for our patients. You see her on the computer in the community, and she is scheduling an appointment, and it's probably for later that day or next day. They also provide transportation for our patients, which helps remove that transportation barrier. They will pick them up at wherever is convenient. So, our patients don't have a home address that they can say, hey, come see me at One State Road. They really have to be flexible in their transportation service options. From our first year of the program, we saw about a 52% no-show rate at the local FQHC, which is very high. But I want to point out that they never once said, well, we can't see your patients anymore, right? Which happens very frequently in a lot of other specialty practices that we try to get our patients into. They have requirements for their own staff and their own financial points to look through or lenses to look through about what a no-show does to their schedule. And our local FQHC has never once said, well, they missed 4 appointments, so they can no longer come here. And so we actually have seen a great drop in our no-show rate in year 2, which is fantastic. 87% of the patients that we see in street medicine are referred to the local FQHC. And I will point out that that's not just for primary care. We are extremely fortunate in the Pottstown community to have a very comprehensive FQHC. Our FQHC offers primary care services. They are a center of excellence for opioid use disorder. They have dental services, eye care. They have physical therapy. They have a pharmacy on site. They have maternity and women's health services, and they also are a pediatric office. So it is a one-stop shop for healthcare for our patients, and so they are a fantastic partner in that regard. 56% of the patients that we refer through street medicine have completed at least one in-office appointment. And that bottom number, I think, is what we're most proud of and looking to continue to see that grow, is that 39% of our patients continue to engage in routine care. So they don't just show up once for an appointment. They've established a routine set of care where they've gone to at least 2 or more in-office visits. We have several patients who have been there more than 5 or 6 times at this point. So we really are starting to see that routine care getting established in the primary setting. Next slide.
Let me just stay right there for, okay,
Sure.
let me just add one thing to that slide. The scenario, the person on the left is a person who was seen in the clinic, and this is the principle of knowing your population and then adjusting your service. So one of the hardships for people who are homeless is that most of care is dependent on cell phones to be able to call or receive information. And in this picture, she had not received the results of her lab, her recent lab work. And so she had medication, but she wasn't sure what that was about. And so Casey was able to look up in the field and show her lab results from the field, which were the doctors were unable to get to her over the cell phone. The other thing is that we sort of coined a phrase called aggressive care facilitation, which is you figure out what's the barrier. So that drop from 52% to 38% in terms of no-show was because we were figuring out what were the things in that area that were keeping people from being able to get to their clinic appointment, and then adjusting accordingly. Sometimes that meant that staff actually went to find the people before their appointment, locate them, put them in a vehicle, and get them to their clinic appointment. But whatever we needed to do to address those needs was what was happening. And so it's an example of adjusting your service even further once you're in there and you're learning about what works and what doesn't, and knowing the needs of the people who are unable to otherwise use the service effectively. Next slide. Thanks, Casey. So here are some of the things that we've learned from our pilot and from our project so far. The first thing is that you need champions. And it's not just the service and the partnerships that you form. You have to have the right people in those services. So Casey talked about Gladys. The reason it was so helpful, and Gladys was one of the first people that the FQHC sent out, and she was the right person. So the people that you need are people who can figure things out, who are comfortable being in a situation where we're not sure of all the answers just yet. They like that. And then you have to give them the sanction and the latitude to make some adjustments. So when she came back to the FQHC and said, this is what we need to do to adjust our intake process, or this is what we need to do, we actually had also adjusted it at one point to say, can we get this person into the lab right now? We have them in front of us. We have street med time built into the FQHC day. Can we actually put somebody in a vehicle right now and take them and get the lab done right now? So those are examples of the latitude that Gladys was given in order to make the adjustments that increased their capacity to provide the service well. In this picture, the doctor's on the phone, sort of to the right of the picture. That was one of the original champions at Tower Health. He said, there's a need here, can we meet it? He's not as involved now as he was at that point. And so it's just helpful to know that in the beginning, you're looking for champions that may not be the people who make the project work forever, but they're the people that are going to help you get it started. And there's a certain sort of mentality and passion for service that is important to make those early steps. The second part is to get started even if it's small. We started with very little money, lots of volunteer time, and or absorbing costs within the partners that were there. And we asked the community at large, can you be helpful to us? And there were lots of people in the community, people who were giving food to people or opening the pantry to people, knew that they had folks who were sick and they wanted to see them get care. And so there's lots of people that were willing to start, but we started small, even though we didn't have all of the things figured out. And then decide to learn from your experience. We spent a fair amount of time not being sure exactly what we were doing, but we had confidence that we would learn from it and we would adapt as we went. And so that was really what gave us the sense, even when we felt a little bit tentative or uncertain, that we should keep moving forward because we would figure it out. I remember that first day with Dr. Van Vliet, I wasn't sure we were going to find anybody. I was panicked that I knew there were homeless people and I knew they were sick, but I was afraid we weren't going to find anybody. And so you just have to start, and as you do it, the project will grow. Next slide. And so this is what's next for us. What I just said leads pretty nicely into that first bullet, which is how do you build sustainability, which is sort of the opposite side. We say to start small, But to be able to be sustainable and on sort of a scale, it takes some other things. We know that for about 80% of our healthcare costs is really driven by like 5% of the people. These are people that are hard to serve, and it requires a different tactic. And so we just talked about provider adaptability and provider innovation to be able to do that. And from a provider point of view, it makes good business sense to be able to provide your service well and provide it effectively to the people you're trying to serve. The issue is, the challenge is that adaptability, that flexibility needs to be matched on the funding side of it. And right now, there's not really an incentive for a provider to do what they do differently. The things that we just talked about, finding a champion and then starting small, even though there isn't a great clear pathway to do that, those are things that require additional things from a provider that isn't incentivized on the funding side of it. We're hopeful that as we talk about value-based payment, value-based care, that there will be the latitude for providers to say, this is what we need to do to provide the service well. We're learning about that. We know what we need to do, and we're asking for funders to match that and make it reimbursable for us. There are some parts that are reimbursable. There's lots that there's not reimbursable, but the ability to be innovative and try new things and adapt your processes is something that falls on providers as a requirement. So they have to decide they want to do that. And so we're hoping as we move forward on a larger scale to see reimbursement incentivize the value of innovation. Deb, do you want to talk about replication?
Sure. So right now we are looking at these, we just went through all these great outcomes, and you know, the program here, it's only 18 months old, and we started it in the middle of a pandemic. So what's next for us? We're really looking to take the model that we have and move it to other parts of the county while still keeping the Tower Health model for street medicine, and the same model with street guides, and just partnering with anybody that we can in the different parts of the communities in the county. We know now that there has been some recognition lately around this project in our county, and that has brought new funding opportunities and opportunities to put money to expand this great work to other parts of the county, and we're really excited for that.
Casey, do you want to talk about, this picture has Madeline Dean, and do you want to talk a little bit about the funding that you guys were able to secure?
Absolutely. So it's actually a little bit of a funny story. I got an email one day about some community project funding to be included in the federal budget that you could submit for through our local congresswoman, Madeline Dean. And I thought it was spam at first, actually. And so it took me a few days to open it. But when I finally did, it was a great opportunity to apply for community project funding. After meeting with Madeline Dean and talking about our project locally, she has been extremely supportive in wanting to expand this project to other communities that not only she services, but in our county as well. And our project was one of 10 locally to receive funding through community project. And is included in some funding through the federal budget, specifically through SAMHSA. So we received a grant just shy of $500,000 to expand this project into new areas. Deb mentioned some other funding in the county through the American Rescue Plan Act. We received another grant that will kick off later this month for $1.7 million. And that ties into the second piece there, is that adding that street site component. As you can see from some of our data, we know behavioral health continues to be a challenge for our patients. And not only is it a frequent need of the patients that we serve, but it's our biggest challenge area where we just haven't been able to figure out how to bring those services to the street in a capacity that works for the individuals that we're serving and really removing some of those barriers. And so with this additional funding, we will be adding a psychiatrist to our team to do on-demand, on-the-street psych. And we're really looking forward to that. As you can see in the picture, Madeline Dean came out and got to kind of tour street medicine with us. And we continue looking for additional partners, as Mark said, in other areas of the county. And from our healthcare perspective, if you're not too familiar with the Montgomery County area, our hospital service area is only about a 10-mile radius around the hospital. And so there are several other health entities and health systems in our county. And our goal is, while we're happy to kind of bridge that gap and provide healthcare services to other areas in the county that we may not traditionally serve, we would really love to continue conversations with other healthcare entities and demonstrate how that they can replicate this. We figured it out over the past 18 months. And we're ready to help expand throughout the county they know their local communities better than we do. So while we are here to bridge that gap and provide those medical services and continue the partnerships we've established, we are also looking forward to creating partnerships and conversations with additional healthcare systems to continue to treat their own communities.
Thanks, Casey. And I would just sort of add that this strategy that Casey just described really goes back to those three principles that we talked about at the very beginning. What we have right now are really solid partnerships that we've learned to make really functional. What we don't have is a lot of other entities in other parts of the county who are saying we want to become a partner. That hasn't happened just yet. So we're using the partnerships that we have. The downside is that we're not connected as closely. The healthcare providers aren't connected quite as closely to the local communities, and so we have to build those partnerships with informal partners in those spaces. And so our strategy moving forward, it just reflects what we've learned so far. And when Casey was talking about the street psych, I think one of the things, it goes back to that there's a variability, a sort of a continuum of how readily able our partners are to adjust what they do in their service in order to accommodate the different needs of people who are high utilizers of certain services or haven't been able to use services in their traditional way very effectively. And so one of the hard things is that has just been hard to partner with agencies to provide mental health services, behavioral health services, who can adjust those services very much. And so there's just been a struggle. We see the need. We think we even know how to maybe address that need. One basic example is that most of the providers require somebody to see a therapist for a little bit before they see a psychiatrist. The people who we are serving on the street are very clear on their need for psychiatry, are less interested in seeing a therapist first on their way into becoming a patient of that service. And so there's just sort of a little bit of a disconnect, and the feedback loop with street medicine is really quick. If you don't do it exactly right in an effective way, you just won't have the person. They just won't be there for you. They'll walk away from you because you're trying to find them. So it's an example of what we're trying to do in terms of adjusting our service to meet the need of the person so that they can use that service effectively. The last thing on that slide is that it's been interesting to watch. There's a larger movement afoot in the borough around what to do to support folks who are experiencing homelessness in the borough. There's a shelter that's being planned and it's going through zoning. There's some pushback. There's some public conversation about homelessness in the borough. And one of the things that has emerged is everybody's recognizing that the street medicine team and the hospital are now content experts in terms of what's going on with homelessness in the local community. And Casey was starting to get questions and being asked for data about who are you seeing and where are they. And so it was really cool to watch the hospital become really viewed as a resource in addressing the homelessness population in the borough and looking at the housing issues and becoming a partner in that conversation. So it's expanding out beyond just the provision of care.
I just want to add too, and I don't think we said this in the beginning, when we talk about Pottstown in this program, we're really talking about at most a 2-mile radius of our community. And so seeing 174 unique patients in that very small and fairly suburban space is quite substantial. And it has brought up definitely some larger conversations in our community about the services that are needed and how we can support these individuals with their social needs.
Nice. Thank you, Casey. So that's our presentation. And so I'm going to turn this back over to Brandon and Sharon and take questions at this point.
Thank you guys very much. We do have a few questions, and the first one is a more kind of technical question, which is which parts of this program are reimbursable, and for those parts, who actually submits the claim and to what entity?
Start answering that question, and maybe Mark can jump in a little bit. As far as Tower Health is like our medical portion that we provide, our emergency department providers, this is a community benefit that we offer. So we are currently not getting reimbursed for any care. We are not going through any healthcare insurance for the services that we provide out in the community. This is 100% a community benefit. In fact, most of our actually all of our provider time up until this point has been volunteer, the same with all of our staff. So our fantastic ED providers who are working insanely hard in the ED are taking time out of their busy day to implement this program. We currently do it every Tuesday, and we currently are not getting reimbursed for any of our services. It is just a community benefit that we offer. Mark, do you want to chime in on anything?
Yeah, we don't have the FQHC with us in this presentation. My understanding is that they can bill, and they do bill for their services as if it were an in-clinic appointment. There's time lost, there's indirect costs associated with sending staff out that are not reimbursable. And so it's not as cost efficient from their end, but they are able to recoup some of the provider costs to be able to do that. In terms of the outreach guide, the things that Access Services provides, that's grant funded. And so we've had to procure the funds to do that. Deb has worked tirelessly to make sure there's money behind that. It's taken us a while to be able to add a position, which we've needed to do for quite some time actually, but it's taken us a while to be able to provide for that position. One of the hardships for the behavioral health side is that by sending a person out, staff out into the street, they have some of their time reimbursed when they are seeing somebody, and they can bill for that. But that's not, it's sporadic. So it's not every time they go out. We might see 10 patients, and 3 of them might have behavioral health issues where they can have some contact that might be a billable time, but it's not for the entire time that they're out. So there is cost incurred by the behavioral health provider, which is part of the problem. If a behavioral health provider sees that this is needed, they're willing to do it, they're able to adapt their service, and then they're not able to recoup the costs associated with that. There needs to be incentivizing on the funder side for innovation and adaptability.
The one thing I would add is if street medicine is a new concept for you, I would highly recommend that you check out the International Street Medicine Society and Program. And once you get to know the street medicine community, which is actually surprisingly extensive, there are some programs out there that are actively billing insurance for the services that they're providing. And it's surprising how many of our patients actually have some degree of healthcare, and of course it's often Medicare, Medicaid. And at this point in time, we haven't been trying to bill them, but my understanding is that there are programs out there that do that to help provide financial support for the services that they are providing.
Yeah, and to that point, a lot of our population, a lot of the people that we're serving are Medicaid covered or Medicaid eligible. And so we would love to see sort of traditional payers join us to be able to provide this long-term and sustainably, to be able to take the payment out into the street.
And I can share, upon first visit, about 2/3 of our population is on medical assistance, leaving a third uninsured. And I will say with our partnerships, we're actually able, one of the things that Gladys does is help enroll individuals in health insurance if applicable and appropriate. So we actually do have a higher number of insured patients. More than 2/3 are actually insured now. But when they first come to us, it's about 2/3 have insurance.
And part of the reason that we actually collect that data on insurance, even though we're not actively using it, is some of our partners obviously do. And one of those partners would be our local pharmacy, which has been amazing in helping us make sure that we're able to get patients their medications. And so if we have the patient's Medicare, Medicaid information, they will take that to try and help with their provision of medications and making sure that they're getting reimbursed to the extent possible.
I'm glad you brought that up. We found a partnership in a pharmacy, and it became really, really critical. We didn't know that when we started. We just thought, well, we'll just send somebody to the pharmacy. There's 3 or 4 in that same little geographic area. But this pharmacy wants to serve the people that we serve, and we also realized that they had prescriptions on hand for people that they couldn't find. And so we have a sort of a symbiotic thing happening now where we stop in the morning and say, who are you trying to get medication to? And where there's overlap, we will just take the medication to the folks that we know where to find and they have not been able to get medication to. It's the example of, it's not just partnership, it's finding the right people in the right partnership. It's relational. Are there other questions?
Yeah. So, one of the questions was related to what percentage of your population have some insurance or have eligibility for insurance, and you answered that question. So in that context, Pennsylvania has a pretty rich behavioral health benefit from a Medicaid state plan point of view. Have you thought about, or have you been working with advocates at the state level or advocates at the county's managed care level to add some outreach services? Because I believe that there are reimbursable outreach services on the Medicaid side in Pennsylvania anyway.
We haven't gotten that far. I think where we started was we looked in the geography where we were and say, who's established as a provider, and can we develop a relationship with them? Can we develop a partnership out of that relationship, and then can we help them figure out how can they sort of fill their lane well, and how can they be reimbursed for the service? That's one of the conversations that we always have, is if you were to send somebody out, what happens to your billing picture? And so far, we're really, where we are at 18 months is really helping some of those providers to sort of understand, how's this population different? What do they need differently from you? So as an example, particularly early on, we had providers that would come out and say, well, here's a card and you can make a phone call or schedule an appointment. And it just doesn't work. It doesn't work well for that group of people. They don't have a phone, or their phone's broken, or it's not charged, or they don't have enough minutes on their phone, and they may not be able to take a call back. And so just adopting the idea that you're going to do everything that you need to do when you're physically with that person, and assume that they're not going to be able to follow up real well, and just understand that if you're going to serve this group of people, that's what you need to to be able to do. So I think we're really at this point exploring with partners, what does it take to do it differently in order to be successful with this group of people, and certainly we need to get to how do we help those partners have sustainable funding to provide the service once they figure out how to make those adaptations.
And I think just adding to that advocacy perspective, our community partner, Creative Health Services, is the county provider for us for behavioral health services. And their CEO, executive director, his name is Andy Trentacost. He is a fantastic advocate for the behavioral health communities, and their involvement on this project has been, a great partnership for us that we continue to look to explore in different ways. But Andy is a fantastic advocate for their services, particularly for reimbursement of their services. They've been serving our community for many years, and he and I recently have had a conversation around that. So I think that's a great point of how can street medicine continue to advocate for those avenues and that reimbursement component.
Nice.
And one of the concepts that we've explored within the context of providing mental health care is Casey's been fantastic at trying to harness some of the resources that are already available within our medical system. And so we do have actually a psychiatry residency program. And so we've been considering trying to do some sort of partnership with them. One of the questions that came up was whether or not providing psychiatry services just via an iPad would be an effective way of getting homeless individuals the healthcare, the mental health care that they need. And so that's a very complicated question, is having somebody physically there to interact with them versus somebody digitally addressing their needs. To what extent are we going to be able to adequately provide them with the mental health care that they need in either one of those modalities? So there are a lot of options out there that we're still actively exploring, and we hope to kind of better address mental health care in the year ahead.
Nice.
I wanted to add, kind of ties back to what Sharon said in the introduction about how these behavioral health entities are now adding housing, permanent housing into their services. And HUD recently has really started to kind of key in on this as well. So they have started to release RFPs, long-term sustainable funds around housing and healthcare. We're actually writing a grant right now to support medically fragile people into rapid housing straight from street medicine through our homeless street outreach team. So I think that as this word is getting out more and more, we would love to see our traditional payers jump in, join our project. But as the health organizations, as the housing department, as everybody is kind of seeing this need, more and more opportunities are coming up.
Yeah, and Deborah, I think that's such an important message for everybody. Government is starting to think about programs that more systemically will help address this population. And so it's incumbent really upon everybody to keep your ear to the grindstone, write those grants, make sure that you're getting that money in, because this is a population that clearly is very easy to fall through the cracks if you're not being vigilant. That was our last question. And just want to thank you guys again, both for the excellent work that you're doing, and then also for sharing that work with us and with our audience participants. Brandon, is there any last minute?
Yeah, so again, like Sharon said, thank you so much. Thank you as well to the audience for joining us for today's web forum. I just wanted to take a moment to remind everyone once more, the slides and recording will be available tomorrow on the Open Minds website. Also, the full Circle Elite Executive Roundtable series is available on demand as part of the extensive Open Minds library, and it's also available from the Open Minds YouTube channel as well. Other than that, please join us next week for our roundtable on Thursday, September 22nd at 1 p.m. Eastern Time for our next Circle Elite Executive Roundtable entitled, How Much Do My Services Cost? The Importance of Unit Cost in Service Redesign, the VOA case study. This roundtable is part of the Open Minds CFO Consortium, which is developed to provide executives with the tools and abilities to strategically assess and position their organizations for long-term sustainability and growth. The consortium is open to all elite members. The roundtable presentation will feature Tom Kometz, Chief Financial Officer for Volunteers of America, Indiana and Ohio. Mr. Kometz will discuss the steps for calculating unit costs, providing insights for successfully managing the case rates of new and future services, and will demonstrate how to understand the priority of managing unit costs when implementing value-based alternative payment models. For a full list of upcoming roundtables or to register for the September 22nd event, please visit the Executive Minds Roundtables under the Events tab at www.openminds.com. Thank you all.